We're taking what is essentially a high-speed, high-yield summary of medical knowledge.
The absolute core facts.
Exactly. The foundational stuff you need to understand human disease. And we're turning it into an investigative deep dive.
That's right. This isn't just about reading bullet points. When you see material this dense, it's designed for rapid review, for that instant recall before an exam.
But our mission is totally different.
Totally. We want to take this dense collection of core pathophysiology, classic clinical findings, and essential medical associations, and just unpack it slowly, conversationally. We're going to focus on the mechanism behind every single entry.
The goal isn't fleeting memorization, it's deep conceptual mastery. We want to know the cascading implications of that one first molecular mistake.
Exactly.
We want to understand the why so deeply that the what and the how just click into place. I mean, if we can explain every line in this review material, we can maximize that foundational understanding for you.
Precisely. If you understand how the engine fails, you can recognize the symptoms anywhere. We'll explain not just what the disease is, but how it operates at a cellular or molecular level. That's the truly critical knowledge.
Okay, let's unpack this. Starting where all disease truly begins, with the deepest roots of error, genetics and metabolism. We're looking at the body's molecular blueprint gone awry.
Right at the source code.
So first on the list is Lesch-Nyhan syndrome. It's listed as a brutal X-linked condition, and the core mechanism is a defect in HGPRT. That's hypoxanthine guanine phosphoribosyltransferase.
Yeah, that's a mouthful.
It is. And it says this leads to increased de novo purine synthesis and excessive uric acid. That is a lot of dense biochemistry in one sentence.
It is, and we have to slow down here. So HGPRT is a critical part of the purine salvage pathway.
The salvage pathway.
Think of purines like adenine and guanine as necessary building blocks for DNA and RNA. The salvage pathway is, it's an efficient recycling program. It takes old purine bases that have been broken down and quickly reuses them to make new nucleotides.
So if the recycling enzyme, this HGPRT, is defective because of an X-linked mutation, those old purine bases can't be recycled. What happens instead?
Well, the body still needs purines, right?
Yeah.
So the cell senses this deficit, and it just slams the accelerator on the alternative pathway, the de novo pathway.
The build from scratch system.
Exactly. And the ultimate byproduct of rapidly breaking down those excess purines and ramping up that de novo pathway is a ton of uric acid.
Yeah.
This massive excess of uric acid causes gout and kidney issues.
Yeah.
But the clinical horror of Lesch-Nyhan, I mean, the severe intellectual disability and that absolutely classic self-mutilating behavior,
Yeah.
that's what stands out.
I mean, what's the connection? What's the link between overproduction of uric acid and a child, biting off their own lips and fingers?
The precise link is still being figured out, but it appears to be a secondary effect of this purine dysregulation on dopamine metabolism in the basal ganglia.
Okay, so the part of the brain that controls movement.
Movement and learned behavior, exactly. Specifically, the purine buildup seems to lead to a dopamine deficiency in certain brain regions, creating this profound neurological and behavioral dysregulation. And that results in this extreme, tragic compulsion to self-harm. That failure in one tiny recycling program results in a systemic, devastating neurological failure.
Wow. Okay, moving from enzyme failure to DNA maintenance. Let's discuss Lynch syndrome, or HNPCC. The core mechanism here is the failure of mismatch repair.
Right.
It involves key genes like MLH1 and MSH2 during the S phase of the cell cycle.
So this failure involves the cell's cleanup crew. Every time DNA replicates, which is in the S phase, the DNA polymerase makes mistakes. It just happens.
Like typos.
Exactly like typos. This match repair, or MMR, is the system that rapidly scans the newly synthesized strand for these base pair errors and fixes them. MLH1 and MSH2 are the essential structural components of this error correction complex.
So if that complex is defective, those errors, those typos, are just left uncorrected, which seems like a huge risk factor for cancer.
It's an accelerator pedal for malignancy. The source highlights that this leads to microsatellite instability. Microsatellites are these short repeating sequences of DNA that are especially prone to polymerase errors.
Okay.
If MMR is broken, the lengths of these repeats change rapidly. This instability causes a rapid accumulation of mutations, particularly in genes that regulate cell growth. And that just drives the cell toward carcinoma, often presenting as colorectal cancer in the proximal colon at an unusually young age.
Next, let's contrast beta-thalassemia with its related condition of thalassemia. The source focuses on beta-thalassemia, noting a mutation at the splice site or promoter sequences, which results in reduced or absent vacuolobin synthesis.
This mechanism is very specific. So you remember, hemoglobin is made of 4 globins,
Okay.
the 1 and 2 follow chains. The VUC gene, when it's mutated, causes phthalate. If the mutation hits the promoter, you still make some goglobin, but the quantity is just reduced. That's a BOGO or defect. But if the mutation hits the splice site, the resulting messenger RNA, the instruction manual, is often just gibberish or non-functional, and that leads to completely absent boglobin, a BOGO defect.
So whether it's reduced or absent, the result is an imbalance. You have too much I globin relative to boglobin.
Exactly. The excess I chains are highly unstable, and they precipitate within the red blood cell precursors right there in the bone marrow. This precipitation damages the cells, leading to ineffective erythropoiesis and a severe microcytic anemia.
And how does that contrast with thalassemia?
Well, if we follow the source's prompt here, in thalassemia you have the opposite problem, excess I chains. These excess I chains can form what are called I tetramers, or HBH. Now, HBH is also unstable, but it's less damaging than the I it precipitates. This leads to a different spectrum of disease severity, though the most severe form for I gene deletions is lethal in utero.
Moving from blood structure to overall body structure, we have osteogenesis imperfecta, or OI, brittle bone disease. The mechanism is a mutation in the COL1A1 or COL1A2 genes, leading to a faulty type 1 collagen structure.
And type 1 collagen is the body's fundamental structural rebar. It provides tensile strength everywhere in bone, teeth, tendons, and even the sclera of the eye. The mutation means the triple helix structure, that tightly wound rope that provides strength that just can't form correctly.
So if the rebar is weak, everything is fragile. That perfectly explains the triad. Multiple non-traumatic fractures, dental abnormalities leading to tooth fragility, and conductive or mixed hearing loss because the tiny middle ear ossicles are also structurally defective.
And don't forget the blue sclerae. Because the sclera is mostly collagen, its thinning allows the dark uveal tissue underneath to show through, creating that classic blue tint. It's a visual manifestation of a systemic structural defect.
Ehlers-Danlos syndrome, EDS, is closely related. It involves faulty collagen synthesis, resulting in hyperextensible skin, hypermobile joints, and easy bruising. The source wisely pairs this with Marfan syndrome, which involves defective fibrillin 1.
Right, and this pairing really helps us understand the difference between a primary structural failure and an elastic fiber failure. EDS is literally a faulty blueprint or process for building collagen. The connective tissue is loose, stretchy, and weak, like a poorly braided rope.
And Marfan?
Marfan, on the other hand, is a defect in fibrillin 1, which is a key component of elastic fibers. Elastic fibers are crucial for tissues that have to stretch and recoil, like the lungs and, most critically, the aorta.
So while both are connective tissue disorders, the implications differ. EDS often involves musculoskeletal instability, while Marfan primarily involves life-threatening aortic root dilation and dissection because the aortic wall just can't handle the pressure changes.
Yeah.
Now for a really interesting topic, genomic imprinting. We have Prader-Willi and Angelman syndromes. They share a complex mechanism involving imprinting or uniparental dissection on chromosome 15.
Imprinting is a remarkable biological concept. For certain genes, only the copy inherited from one parent is active, the other is chemically silenced or imprinted. And the genes on the specific region of chromosome 15 are crucial for neurological development, and they are differentially regulated based on parental origin.
In Prader-Willi, the issue is the deletion or UPD of the paternal allele.
Right, the paternal copy is the one that's supposed to be active here. So if that active copy is missing, or if the child inherits two copies of the mother's silenced chromosome 15 maternal UPD, they lack the necessary paternal gene products.
And that leads to the classic signs.
It does. It leads to the characteristic hypotonia at birth, developmental delay, and most famously that unrelenting pathological hunger or hyperphagia that leads to morbid obesity.
Conversely, Angelman syndrome is the deletion or UPD of the maternal allele, which affects the UBS gene.
In Angelman, the maternal copy of UBISA is the active one. If that's deleted, or if the child inherits two silenced paternal copies, the UBISA protein, which is an E3 ubiquitin ligase involved in protein degradation, is missing.
Which results in a completely different clinical picture.
Completely different. You get severe intellectual disability, motor issues, seizures, and these inappropriate frequent bursts of laughter that earn it the happy puppet nickname. It's the same piece of genetic real estate, but the outcome hinges entirely on the parent of origin.
Let's turn to cystic fibrosis, or CF. The mechanism is the F508 deletion in the CFTR gene, leading to an impaired ATP-gated chloride channel.
This is the most common mutation by far. The CFTR protein is a chloride channel. The F508 deletion results in a misfolded protein, and the cell's quality control system recognizes this misfolding, and rather than letting a faulty channel get to the surface, it tags the protein for rapid destruction in the proteasome.
So the problem isn't just that the channel doesn't work well. The problem is that it never reaches the cell membrane to begin with.
Exactly. And this scarcity of functional chloride channels leads to disastrous consequences in epithelial tissues. In the lungs and pancreas, the lack of chloride secretion impairs water flow, leading to thick, obstructive mucus.
But in the sweat glands, it's different.
It's the opposite. In the sweat glands, the CFTR channel's job is reabsorption. And because it fails to reabsorb chloride, the patient loses massive amounts of salt in their sweat. And that gives us the key diagnostic finding: elevated sweat chloride. That mechanism failure to reach the surface is absolutely crucial.
Finally, in this subsection, Menkes disease, defective ATP7A protein impairing copper absorption and transport. Why is copper so central to structural health?
Copper is an essential micronutrient cofactor for dozens of enzymes. ATP7A is the primary transporter that absorbs copper from the gut and moves it throughout the body. When it's defective, the patient becomes severely copper deficient, and that leads to a cascade of enzyme failures.
Which enzyme failure gives the disease its classic features?
The failure of lysyl oxidase. Lysyl oxidase is a copper-dependent enzyme that's essential for cross-linking collagen and elastin. Without proper cross-linking, connective tissues are weak and arteries are fragile. This explains the characteristic kinky hair, cerebral degeneration, and arterial issues seen in Menkes, which tragically leads to neurodegeneration and early death.
Now for deficiencies, Wernicke encephalopathy is thiamine or B1 deficiency. The mechanism is impaired glucose breakdown and ATP depletion, which is exacerbated by glucose infusion.
Thiamine, in its active form, TPP, is a required cofactor for key enzymes in energy metabolism. Pyruvate dehydrogenase, which connects glycolysis to the Krebs cycle, and ketoglutarate dehydrogenase, a rate-limiting step in the Krebs cycle itself. If thiamine is low, you essentially stop the primary way the cell generates energy from glucose.
And the brain, being the most metabolically demanding organ, suffers first.
Precisely. That leads to the classic triad of confusion, ophthalmoplegia, and ataxia. And this is the critical point. If you give a malnourished patient who may have dangerously low thiamine stores a large bolus of glucose,
You're just fueling the fire.
you're demanding that the little remaining thiamine be used up instantly to try and metabolize that glucose. This rapid depletion exacerbates the energy crisis in the brain, plunging them deeper into the encephalopathy. That's why you must always administer thiamine before glucose.
Next, pellagra or niacin, B3 deficiency. The mechanism is fascinating. Tryptophan gets diverted towards serotonin synthesis, leading to B3 deficiency, which then impairs the NADH-NAD ratio.
Tryptophan is an essential amino acid. It's the precursor not only for serotonin but also for niacin. If tryptophan is diverted, as happens pathologically in carcinoid syndrome, or if the diet is severely tryptophan deficient, like in corn-based diets without supplementation, the niacin synthesis pathway just starves.
And niacin is essential because it forms the electron carriers NADO and NADH.
The absolute foundation of cellular respiration. Without sufficient NAD, cellular energy plummets, especially in high-turnover tissues. And that gives us the classic 3Ds: dermatitis, which is often photosensitive like a collar or a glove, diarrhea due to high epithelial cell turnover failure, and dementia due to nervous system failure.
Let's contract essential fructosuria and galactosemia 2 carbohydrate enzyme defects with wildly different implications. Fructosuria involves fructokinase deficiency.
Right, and galactosemia involves galactose-1-phosphate uridyl transferase deficiency, or GALT.
So fructosuria.
Essential fructosuria is a textbook benign condition. Fructokinase converts fructose to a usable intermediate. If it's missing, fructose simply accumulates in the blood and is excreted harmlessly in the urine. It's an interesting lab finding, but clinically irrelevant.
Galactosemia, however, is a pediatric emergency.
It is extremely toxic. The missing GALT enzyme leads to the accumulation of galactose-1-phosphate, which is directly toxic to the liver, brain, and kidneys. And crucially, alternative enzymes convert the excess galactose into a sugar alcohol called galactitol.
And that's what causes the cataracts.
Exactly. Galactitol accumulates in the lens of the eye,
Yeah.
causing massive osmotic swelling and rapid cataract formation, along with the risk of liver failure, sepsis, and developmental disability.
This mechanism of sugar-alcohol accumulation brings us directly to diabetic complications: cataracts, retinopathy, and neuropathy. The source pins the blame on the sorbitol pathway.
This is a perfect example of how the body attempts to process excess, leading to damage. In tissues that don't require insulin for glucose uptake, Like the lens, the retina, and Schwann cells that myelinate peripheral nerves' excess glucose just floods in when blood sugar is high.
Okay.
The enzyme aldose reductase then attempts to clear this glucose by converting it into sorbitol.
And sorbitol is a trap.
It is. Sorbitol is a potent osmolyte. It pulls water into the cell. Furthermore, the enzyme required to clear sorbitol further, sorbitol dehydrogenase, is slow or saturated, so sorbitol and water accumulate, leading to massive osmotic stress, swelling, and eventual damage to those tissues. This mechanism explains the microvascular and neurological damage seen chronically in diabetes.
Okay, let's pivot to the systems of attack and defense, starting with the fundamental categorization of immune overreactions. Hypersensitivity reactions, types I through 4. Getting these mechanisms straight is vital.
Absolutely. So type I is the immediate type. It's mediated by IgE binding to mast cells, which triggers degranulation and the release of histamine and leukotrienes.
This is the fastest reaction, right? The classic bee sting or peanut allergy.
It is, but it requires sensitization first. The first exposure generates allergen-specific IgE. These IgE molecules then fix themselves to the surface of mast cells and basophils.
They're just waiting there.
They are. The second exposure cross-links these surface-bound IgE molecules, and that instantly triggers the explosive release of preformed mediators like histamine, which cause vasodilation and bronchoconstriction, and newly synthesized leukotrienes. This all leads to the rapid symptoms of anaphylaxis or asthma.
Type 2 is cytotoxic. The mechanism. Antibodies bind to cell surface antigens, activating complement and causing direct cell destruction.
So the antibody here is fixed to the target cell itself. Think of it as a flag planted on the cell membrane, marking it for destruction.
Like an Rh incompatibility reaction.
A classic example, or a hemolytic transfusion reaction. The IgG, or IgM, binds the foreign antigen on the red blood cell surface and calls in a complement cascade, which lasses the cell, or tags it for destruction by phagocytes. It's localized, targeted cell death.
Type 3 is immune complex-mediated mechanism. Antigen-antibody complexes form in circulation, get trapped, activate complement, and attract neutrophils, which release lysosomal enzymes.
The key distinction from type 2 is that the antigen is soluble. It's not attached to a cell. These circulating complexes get filtered out and deposited in narrow spaces, like the capillaries of the skin, joints, or the glomeruli of the kidney. Once they're deposited, they become an inflammatory hotspot, activating C3a and C5a, which are potent chemoattractants.
So the complex itself isn't doing the damage. It's the massive recruitment of neutrophils responding to that complex that's the problem.
Precisely. Neutrophils arrive, they attempt to phagocytose the complexes, and in the process, they release their lysosomal contents, these destructive enzymes, into the surrounding healthy tissue. And that causes necrotizing vasculitis, arthritis, or glomerulonephritis, seen classically in lupus.
And type IV is the outlier delayed or cell-mediated. No antibodies. It's a T-cell-mediated response involving APCs and CD4 T cells.
This is a purely cellular event. An antigen-presenting cell, an APC, picks up an antigen, like a metal ion or a protein fragment, and presents it to a helper CD4A T cell. These T cells then proliferate and release cytokines, notably IFNO, which recruit and massively activate macrophages.
And that's where the delayed part comes from.
The delay comes because it takes a day or two for the T cells to multiply and migrate to the site of exposure. This mechanism is responsible for the classic tuberculin skin test and graft rejection.
Let's look at DeGeorge syndrome, a 22q11 microdeletion leading to failure of the third and fourth pharyngeal pouches. This is a failure of developmental anatomy.
It is a critical congenital defect. These pharyngeal pouches are embryonic tissues that give rise to the parathyroid glands and the thymus. If they fail to develop, the consequences are immediate and severe.
No parathyroids, no thymus.
Right. No parathyroid glands means hypocalcemia or low calcium, leading to tetany and seizures. And no thymus means T-cell maturation is severely impaired, resulting in severe T-cell lymphopenia and vulnerability to recurrent fungal and viral infections.
Leukocyte adhesion deficiency, LAD type 1, involves a defective LFA1 integrin, or CD18 defect, which impairs phagocyte migration and chemotaxis.
LFA1 is the essential sticky molecule, the adherence protein that neutrophils need to cling to the inner wall of the blood vessel before squeezing through into the tissue. This process is called diapetesis. If CD18 is defective, the neutrophils are effectively trapped in the bloodstream.
So clinically, you see a high white blood cell count in the blood, but no cells at the site of infection.
Exactly. The patient just can't mount a normal inflammatory response. This leads to recurrent, non-healing bacterial infections and critically delayed separation of the umbilical cord because the necessary influx of neutrophils and inflammation needed to clear the stump never occurs.
Next, chronic granulomatous disease, CGD, and NADPH oxidase defect. We have to emphasize the importance of the oxidative burst here, as its failure is the defining feature.
When a phagocyte engulfs a microbe, its primary weapon is the oxidative burst. It uses NADPH oxidase to convert oxygen into superoxide, ORO, which is the first step in creating lethal reactive oxygen species, or ROS.
Okay.
In CGD, NADPH oxidase is broken. The neutrophil can engulf the bacteria, but it cannot generate the toxic internal environment needed to kill it.
This makes them uniquely vulnerable to certain types of bacteria, right?
Only to catalase-positive organisms. Catalase-negative organisms, like strep, produce enough HORs on their own that the neutrophil can bypass the NADPH oxidase defect and still kill the invader. But catalase-causative organisms, like Staph aureus or Aspergillus, destroy any surrounding HO. The neutrophil is left completely impotent, resulting in persistent infection and the body's only defense walling off the infection with granulomas.
Let's discuss tetanus and botulism side by side. Both target snare proteins, which are essential for neurotransmitter vesicle release, yet the clinical outcomes are diametrically opposed.
They are two sides of the same molecular coin. Snare proteins are the docking machinery that allow the neurotransmitter vesicle to fuse with the presynaptic membrane and release its contents. Both toxins are proteases that just cleave these snare proteins.
Tetanus toxin travels centrally to the spinal cord and inhibits the release of inhibitory neurotransmitters, GABA and glycine, from Renshaw cells.
So by blocking inhibition, the motor neurons are continuously firing. This results in the state of constant muscle tension, rigidity, and spasms, the spastic paralysis seen in lockjaw.
Botulism toxin, on the other hand, acts peripherally at the neuromuscular junction, and it blocks the release of the excitatory neurotransmitter, acetylcholine.
By blocking excitation, the muscle receives no signal whatsoever. This results in a descending flaccid paralysis. The muscles just go limp. It's really incredible that the location and the specific neurotransmitter affected, not the molecular target, dictates the profound difference between a rigid, spastic death and a floppy, flaccid death.
Diphtheria is a potent toxin that inhibits protein synthesis via ADP ribosylation of elongation factor 2, or EF2.
EF2 is required for the ribosome to move along the mRNA strand during translation. ADP ribosylation inactivates EF2, which halts all protein production in the infected cell. This systemic failure is why diphtheria can cause severe systemic effects like myocarditis and neuropathy on top of the local pseudomembrane in the throat. This mechanism is shared, incidentally, with the Pseudomonas exotoxin A.
The outline links this mechanism to the potential finding of pseudomembranous colitis caused by C. difficile. How do those connect?
Well, while the specific toxins are different, diff toxins A and B primarily disrupt the cytoskeleton and tight junctions of the colon epithelium. The idea of a potent bacterial toxin causing overwhelming local and potentially systemic damage is the connection. C. diff toxins cause massive inflammation and necrosis in the colon lining, leading to that characteristic pseudomembrane.
Let's detail Mycobacterium tuberculosis virulence. The source mentions cord factor, which activates macrophages and inhibits phagolysosomal fusion, and sulfatides, which also inhibit phagolysosomal fusion.
Tuberculosis is a master of intracellular survival. When a macrophage engulfs the bacillus, it forms a phagosome. The cell's goal is to fuse that phagosome with a lysosome full of destructive enzymes.
Right.
The sulfatides act like a blockade, preventing this fusion, allowing the bacteria to live and replicate safely within the macrophage. The cord factor is also a surface glycolipid that promotes granuloma formation and contributes to the organism's serpentine growth pattern in culture.
And this leads us to the spectrum of leprosy. We contrast the effective Th1 response, which is tuberculoid, with the ineffective Th2 response, which is lepromatous and lethal. What dictates this outcome?
The type of helper T-cell response is the entire story here. MLPRE is an intracellular pathogen. The Th1 response generates cytokines, particularly IFNA, which is essential for activating macrophages to destroy the bacteria inside the cell.
So a good Th1 response contains the infection.
If the patient mounts a strong Th1 response, the tuberculoid form, the infection is contained, lesions are localized, and the disease is milder. If, however, the patient mounts a primarily Th2 response, that favors humoral or antibody immunity. Antibodies are useless against bacteria hidden inside cells.
So the immune system is using the wrong tool for the job.
Exactly. This failure of cellular immunity leads to uncontrolled proliferation, a massive bacterial load, and the severe, disfiguring, and lethal lepromatous form.
Finally, the HIV mechanism, binding CD4 along with CCR5 or CXCR4 on T cells.
The CD4 receptor is the key that opens the door. but the virus needs a co-receptor, a door handle, to actually enter the cell. Early in the infection, the virus often uses CCR5, which is primarily found on macrophages and memory T cells. This is the slower, earlier phase.
And later on.
As the disease progresses, the virus often mutates to use CXCR4, which is prevalent on naive CD4 T cells. And this leads to a much faster catastrophic destruction of the T cell population and the clinical definition of AIDS.
Now we move to the systems of flow, the mechanical failures of the heart, the vessels, and the blood itself.
The development of a heart is a complex dance of septation, and a major failure point is the aortopulmonary septum, that spiraling wall that separates the outflow of the ventricles into the aorta and the pulmonary artery.
And patent truncus arteriosus and detransposition of the great arteries are both defined by the failure of this septum to form properly or to spiral. Why is this so lethal so early on?
In truncus arteriosus, the septum never forms, so there's just one large artery receiving blood from both ventricles. This means massive mixing and immediate heart failure. In detransposition, the septum forms straight instead of spiraling.
So the plumbing is just wrong.
The plumbing is completely wrong. The aorta is connected to the right ventricle and the pulmonary artery to the left. This creates two completely separate, non-communicating circulations, one pumping deoxygenated blood to the body and one pumping oxygenated blood back to the lungs. Survival beyond a few hours is impossible without some form of mixing shunt, like a PDA.
Tetralogy of Fallot involves 4 components: pulmonary stenosis, RV hypertrophy, overriding aorta, and a VSD. The mechanism of the infamous TET spells is a perfect example of hemodynamic consequences.
The foundational problem is the severe pulmonary stenosis, that obstruction to flow out of the right ventricle to the lungs. During a TET spell, which can be triggered by stress or crying, the child's systemic vascular resistance, the SVR, suddenly increases, or the RV outflow tract spasms.
So it becomes even harder to pump blood to the lungs.
Much harder. So because it's easier to push blood across the VSD into the high-pressure systemic circulation than it is to push it past the tight pulmonary stenosis, the blood shunts heavily right to left.
And the sudden shunting of deoxygenated blood into the body causes acute, profound cyanosis.
It does. And the reflex behavior of a child who's having a TET spell is often to instinctively squat. Squatting kinks the arteries in the legs, which powerfully increases the SVR. This increased SVR makes it less favorable for the blood to shunt right to left, momentarily favoring flow through the pulmonic valve, improving oxygenation and breaking the spell.
Eisenmenger syndrome. This is the tragic endpoint of an uncorrected chronic left-to-right shunt.
This takes years to develop. If a patient has a large VSD or PDA, blood continuously shunts from the high-pressure left side to the low-pressure right side and then into the pulmonary circulation. Over years, this constant deluge of high volume and high pressure permanently damages the delicate pulmonary arteries, causing irreversible pulmonary hypertension and remodeling.
And eventually the pressure on the right side becomes higher than the left.
Right. Once the pressure in the pulmonary circuit exceeds the pressure in the systemic circuit, the shunt reverses.
And that reversal means deoxygenated blood moves right to left, leading to late-onset cyanosis. This is where the prognosis becomes dismal.
The fixed pulmonary hypertension makes the reversal permanent. The patient develops cyanosis, clubbing, and severe irreversible damage to the right side of the heart.
Finally, let's detail atherosclerosis. The progression is key. Endothelial cell dysfunction, then macrophage and LDL accumulation, foam cell formation, fatty streaks, fibrous plaque, and finally complex lesions.
This is a classic inflammatory disease of the vessel wall. It starts with damage to the endothelium, often from sheer stress or toxins. This damage allows LDL, the bad cholesterol, to seep into the intima layer. The body sends macrophages to clean up, but they become overwhelmed, gorging themselves on oxidized LDL and becoming lipid-filled foam cells.
And the foam cells accumulate, and the body tries to wall them off.
That accumulation forms the fatty streak. The body then attempts a misguided repair, where smooth muscle cells migrate from the medial layer, proliferate, and lay down a fibrous cap over the fatty core. This is the fibrous plaque. The danger is that this cap is brittle. If the plaque ruptures, the highly thrombogenic contents are exposed to the blood, leading to the rapid, acute formation of a life-threatening thrombus.
And the mechanism of myocardial infarction, or MI, is a direct consequence of that last step. Rupture of a coronary artery atherosclerotic plaque leading to acute thrombosis.
The sudden blockage, not the pre-existing narrowing, is the cause of the MI. That rupture exposes tissue factor and other components of the subendothelium, triggering an immediate massive platelet and fibrin cascade that just seals the artery shut. Without blood flow, the downstream myocardium rapidly becomes ischemic and necrotic.
Hypertrophic cardiomyopathy, HOCM, is a genetic disease of the heart muscle structure itself. A sarcomere protein gene mutation leading to concentric hypertrophy. Why is concentric hypertrophy so problematic?
It's a mutation in the contractile machinery like myosin or troponin. Concentric hypertrophy means the muscle cells are added in parallel, causing the walls to thicken inwards and the ventricular cavity size to shrink dramatically.
So it can't fill properly.
Exactly. The immediate consequence is poor filling diastolic dysfunction. But the greatest danger comes from the asymmetric thickening of the septum, which can physically obstruct the outflow tract, especially during exertion. And that can lead to syncope or sudden cardiac death due to malignant arrhythmias.
Wolff-Parkinson-White, WPW, is an electrical shortcut. The mechanism is an abnormal accessory pathway, the bundle of Kent, from the atria to the ventricles.
Normally, the AV node serves as a traffic cop, slowing the signal down. The bundle of Kent is an electrical bypass. The signal travels down this bypass rapidly and prematurely, partially depolarizing the ventricle and creating that characteristic ECG finding, the delta wave.
Why is that so dangerous?
This rapid pathway is dangerous because it often forms a reentrant circuit, allowing the electrical signal to loop rapidly back and forth between the atria and ventricles, causing a potentially fatal supraventricular tachycardia, or SVT.
Let's define the four major shock types by their hemodynamic signature: hypovolemic, cardiogenic, obstructive, and distributive.
We have to look at two variables: cardiac output, CO, and systemic vascular resistance, SVR. Shock is inadequate perfusion.
And hypovolemic and cardiogenic shock are failures of flow, so they have a low CO.
Right. Hypovolemic is a failure of volume-decreased preload from hemorrhage or dehydration. Cardiogenic is a failure of the pump-decreased contractility from a massive MI. In both, the body attempts to compensate by massively clamping down the vessels, which leads to high SVR. That's why the patient feels cold and clammy.
Obstructive shock is physical interference with flow.
Here, the heart might be fine, but something is physically blocking its output or filling a massive pulmonary embolism, a tension pneumothorax or cardiac tamponade. CO is low and SVR is typically high.
And distributive shock is the anomaly, a massively decreased SVR.
This is a failure of regulation. In conditions like sepsis or anaphylaxis, there is massive inappropriate vasodilation. The vessels just lose their tone. Even if the heart compensates with a high CO, the massive drop in SVR means blood pressure, the MAP, plummets catastrophically. These patients are often warm and flush because their vessels are wide open.
Let's talk coagulation, sickle cell anemia. A COINT mutation, glutamic acid to valine invaglobin, which leads to HB polymerization under low oxygen, then sickling, hemolysis, and vaso-occlusion.
This is a perfect example of how one substitution, a hydrophilic glutamic acid replaced by a hydrophobic valine, creates a sticky patch on the hemoglobin molecule.
Right.
When oxygen tension drops, like in capillaries or during an infection, these sticky patches interact, polymerizing the hemoglobin into rigid rods. These rods distort the cell into the sickle shape, making them rigid, prone to destruction, that's the hemolysis, and leading to the painful capillary blockages, the vaso-occlusive crises that define the disease.
Thrombotic thrombocytopenic purpura, TTP, is the ADAMTS13 deficiency. This medulla protease degrades von Willebrand factor multimers.
VWF is critical for initial platelet adhesion. It exists in these huge, long multipamers. ADAMTS13 is the molecular scissors that cuts these massive VWF strings into smaller, manageable pieces.
And if the scissors are broken?
If ADAMTS13 is deficient, either genetically or, more commonly, due to an autoimmune antibody, these massive VWF strings persist and act like sticky nets, spontaneously capturing and aggregating platelets throughout the microcirculation, even without any injury.
This causes microthrombi and consumes platelets rapidly.
Yes. The consumption leads to thrombocytopenia, or low platelets, and the widespread microthrombi cause microangiopathic hemolytic anemia, MAHA, along with neurological and renal complications, the classic TTP PINTAD.
Factor V Leiden is the most common hereditary hypercoagulable state. The mechanism, an ARG506G mutation, making factor V resistant to degradation by protein C.
Protein C is a powerful natural anticoagulant that must inactivate factor VA and ADIA to shut down the clotting cascade. The ARG506KMN mutation changes the cleavage site on factor V, making it resistant to protein C's scissors. The result is that factor V stays active longer, pushing the coagulation cascade toward thrombosis and significantly increasing the risk of venous thromboembolism.
Let's distinguish between the two types of heparin-induced thrombocytopenia, HIT.
Type 1 is a minor transient drop in platelets due to a direct heparin effect. It's harmless. Type 2 is the severe immune-mediated life-threatening condition.
And what's the mechanism there?
Here, IgG antibodies form against the heparin platelet factor 4 complex. This antibody binding activates the platelets, leading to massive consumption, the thrombocytopenia, and paradoxically causing severe, widespread thrombosis due to the highly activated state of the remaining platelets.
Now we explore the regulatory systems, starting with the digestive tract and its responses to chronic injury. Barrett esophagus.
Right, Barrett esophagus is the body's attempted defensive transformation. Chronic GERD causes constant acid injury to the lower esophagus.
And the normal lining is non-keratinized stratified squamous epithelium, which is designed for abrasion, but not for acid.
So the tissue undergoes metaplasia. It transforms into intestinal epithelium non-ciliated columnar cells with goblet cells, which is much more acid tolerant. The so what here is that while the new lining handles the acid, it is inherently unstable and carries a significantly increased risk of progressing to esophageal adenocarcinoma.
Meckel diverticulum is a common congenital anomaly, persistence of the vitelline or omphalomycenteric duct.
This duct connected the midgut to the yolk sac in utero and should completely regress. If it persists, it forms an outpouching. The critical clinical point is the rule of twos, but more importantly, it often contains heterotopic tissue, typically gastric or pancreatic.
It's secreting acid where it shouldn't be.
Exactly. The gastric tissue secretes HCl, leading to ulceration, bleeding, and potential perforation.
Hirschsprung disease, another congenital failure, is a loss-of-function mutation in the RET gene, leading to the failure of neural crest migration.
Neural crest cells migrate caudally, or downward, to form the enteric nervous system, the intrinsic wiring of the gut that coordinates peristalsis. When this migration fails, a segment of the distal colon and rectum lacks the necessary ganglion cells.
The Auerbach's and Meissner's plexuses.
Right. This segment is perpetually contracted, obstructing the flow and causing the proximal colon to dilate massively, leading to constipation and functional obstruction.
Rey syndrome is a major pediatric warning. Aspirin use, typically following a viral illness, leads to Boss oxidation failure and inhibition of mitochondrial enzymes.
Rey syndrome is a severe, acute fatty liver and encephalopathy. Aspirin, particularly during a viral infection like influenza or varicella, has a direct toxic effect on the mitochondria in hepatocytes. This cripples fatty acid bioxidation, leading to massive fat accumulation in the liver.
And that's what causes the encephalopathy.
The mitochondrial damage also prevents the urea cycle from functioning, which causes ammonia to build up, and that results in acute encephalopathy.
Speaking of ammonia, hepatocellular carcinoma is often preceded by cirrhosis, which leads to portal systemic shunts and NH metabolism failure, resulting in hepatic encephalopathy.
Cirrhosis creates scar tissue, raising pressure in the portal circulation. To decompress, the blood finds alternative routes, portal systemic shunts, bypassing the liver entirely. This means blood rich in intestinal toxins, especially ammonia, skips the liver's detoxification system.
And ammonia is highly neurotoxic.
It is. It causes swelling of astrocytes and disruption of neurotransmission, leading to the confusion, lethargy, and asterixis, the flapping tremor characteristic of hepatic encephalopathy.
Wilson disease is another critical failure in transport. Defective copper-transporting ATPase, ATP7B, which impairs copper excretion into bile and leads to copper accumulation in the liver, brain, and cornea.
The ATP7B protein, located in the liver, is tasked with two jobs: loading copper onto ceruloplasmin for transport and excreting excess copper into the bile. If ATP7B fails, both functions cease.
So the copper just builds up.
It builds up in the liver, killing hepatocytes, and eventually spills into the circulation, depositing in the brain, causing psychiatric and movement disorders, and in the cornea, manifesting as the classic Kaiser-Fleischer rings.
Let's contrast hyper and hypothyroidism mechanisms, specifically looking at how they impact the Na-Ka attitude.
Thyroid hormone, T, is the thermostat of the body. Its primary action at the cellular level is stimulating the Na-Ka ATPase. This pump consumes huge amounts of ATP, just maintaining the cellular gradients. This energy expenditure is heat generation or calorigenesis.
So in hypothyroidism or myxedema, T is low. The Na-Ka ATPase activity decreases, leading to a decreased basal metabolic rate, cold intolerance, and weight gain.
The furnace is turned down. Conversely, in hyperthyroidism, the massive increase in T-war overstimulates the Na-Ka ATPase, leading to massive ATP consumption, an increased basal metabolic rate, heat intolerance, and weight loss.
And Graves' disease has a unique mechanism for its ophthalmopathy, lymphocytic infiltration, and fibroblast secretion of GAGs.
This is a type 2 hypersensitivity reaction. The stimulating antibodies in Graves' disease don't just target the thyroid TSH receptor. They cross-react with similar antigens found on fibroblasts in the orbital space.
Okay.
These activated fibroblasts then secrete massive amounts of glycosaminoglycans, or GAGs. GAGs are highly hydrophilic, drawing large amounts of water into the muscle and fat behind the eye, causing osmotic swelling, inflammation, and forcing the eyeball forward. Proptosis.
Finally, hyponatremia and SIADH. ADH increases, causing water retention. The compensatory mechanism then kicks in. Aldosterone decreases, while ANP-BMP increases, promoting urinary NIU excretion.
Too much ADH means the kidney retains pure water, diluting the serum sodium hyponatremia. The body senses the resultant volume expansion, even though it's euvolemic. In response, volume receptors inhibit aldosterone secretion, so sodium isn't retained, and trigger the release of ANP and BMP.
And these hormones make you excrete sodium.
Exactly, they act to excrete sodium and water. So the result is a paradox. The patient is overhydrated, but they're still excreting sodium in the urine, a high urinary NAD, because the body is desperately trying to correct the perceived volume overload.
Okay, we must nail the 3 RTAs. All cause metabolic acidosis, but the location of the defect dictates the urine pH and potassium levels.
RTA type 1 is distal. The defect is a decreased ability to secrete AID. The final step in acid excretion fails.
If you can't secrete H, you can't generate new bicarbonate to buffer the blood, causing acidosis. And then urine remains alkaline, right?
Exactly. Urine pH is high, over 5.5, because the final acidification pump is broken. The urine is also often hypokalemic because the damaged distal tubule doesn't affect potassium handling in the same way.
RTA type 2 is proximal. Defective PCT HTO reabsorption.
The PCT is responsible for the bulk reabsorption of bicarbonate. If that fails, bicarbonate is simply dumped into the urine. You get metabolic acidosis. However, once the plasma bicarbonate level drops low enough, the distal tubule's HU secretion capacity is sufficient to acidify the remaining urine, so the urine pH can eventually drop below 5.5.
And RTA type 4 is hyperkalemic RTA. This is associated with hypoaldosteronism or aldosterone resistance.
Aldosterone is the CoH, NH secretor. Deficiency or resistance to aldosterone causes potassium to rise hyperkalemia. High CoH is the driver of the acidosis here because high CoH inhibits the kidney's ability to synthesize ammonia, NH,
which is needed to excrete acid.
Ammonia is the crucial buffer needed to excrete A. Reduced NHA means reduced HA excretion, leading to acidosis.
Let's contrast nephritic versus nephrotic syndrome.
Nephritic syndrome is defined by inflammation. It involves damage and rupture of the glomerular basement membrane, the GBM, allowing red blood cells to pass into the urine hematuria, RBC casts. It presents with hypertension and often oliguria.
And nephrotic syndrome is defined by protein loss.
The primary defect is damage to the podocytes, the cells that maintain the electrical charge barrier. The negative charge barrier is lost, allowing massive amounts of negatively charged plasma proteins, especially albumin, to leak out. This massive proteinuria, over 3.5 grams a day, leads to hypoalbuminemia, causing peripheral edema and triggering the liver to produce lipoproteins, resulting in hyperlipidemia.
We have spent so much time on mechanism. Now let's see how these mechanisms translate into observable, memorable clinical findings, the classic snapshots that aid diagnosis. This is where seemingly random symptoms click into place.
Right, starting with ocular and facial findings. That distinct finding of cafe au lait spots, but unilateral, with polystotic fibrous dysplasia, is the hallmark of McCune-Albright syndrome.
And the mechanism behind this combination is fascinating, a somatic mutation in the G's protein pathway.
Because the mutation is somatic, it occurs after fertilization. It's not present in every cell, which leads to a mosaic pattern. The G-state protein is part of a signaling cascade that controls hormone production. Constitutive activation of this pathway explains the unilateral skin and bone lesions, as well as the endocrine hyperfunction, like precocious puberty.
Cherry red spot on the macula, a classic finding for Tay-Sachs or Niemann-Pick disease. Why does that tiny red spot stand out?
These are both lysosomal storage diseases. Tay-Sachs involves GM2 ganglioside buildup. Niemann-Pick involves thingomyelin buildup. The accumulating substance fills the retinal ganglion cells, making the entire retina appear pale or hazy white.
But not the fovea.
The fovea, however, is devoid of ganglion cells, so its normal vascular redness stands in sharp contrast to the surrounding white retina, creating that dramatic cherry red spot.
red, currant, jelly, sputum.
Klebsiella pneumonia.
Why that description?
That is the visual result of the pathogen's thick polysaccharide capsule, which makes it incredibly viscous and resistant to destruction, leading to massive tissue necrosis and hemorrhage in the lung.
Moving to skeletal findings. Gower's sign a child uses their arms to stand up from a squat is pathognomonic for Duchenne muscular dystrophy.
This X-linked disease means the structural protein dystrophin is non-functional or absent. Dystrophin links the muscle cell machinery to the external scaffolding. Without it, the muscle fibers are just destroyed during contraction. The sign is observed because the progressive weakness in the pelvic girdle and thighs forces the child to climb up their own body for leverage.
A neonate with the arm in a waiter's tip position adduction, internal rotation, suggests herb palsy, C5-C6 root damage.
This is a traction injury to the upper trunk of the brachial plexus during birth. The C5 and C6 roots supply the muscles that externally rotate and abduct the shoulder. The loss of these muscles leaves the arm internally rotated, adducted, and pronated, the classic tip position.
We contrast Osler nodes and Janeway lesions, both associated with infective endocarditis. One is painful, the other is painless.
Osler nodes are painful because they are small inflammatory nodules resulting from immune complex deposition, a type 3 hypersensitivity vasculitis causing inflammation and pain in the fingertip pads. Janeway lesions are painless because they are septic microemboli, small pieces of bacteria and fibrin breaking off the heart valve vegetation and lodging in the skin of the palms and soles, creating small microabscesses without an immediate immune reaction.
Finally, in neurology, chorea, dementia, and caudate degeneration define Huntington disease.
The genetic cause is a massive, unstable CAG trinucleotide repeat expansion. This leads to the buildup of a toxic Huntington protein that selectively kills GABAergic inhibitory neurons in the caudate nucleus and putamen. Loss of this inhibition results in the involuntary jerky movements, the chorea, and the progressive cortical atrophy that leads to dementia.
Here's where it gets really interesting. The microscopic and imaging details that confirm the diagnosis. Let's start with hematology. Basophilic stippling of RBCs, these ribosomal precipitates, are seen in lead poisoning, thalassemia, and sideroblastic anemia.
These are aggregates of ribosomal RNA. In a healthy, maturing red blood cell, this RNA is cleared out. In these three conditions, the clearance is inhibited either by enzyme damage in lead poisoning or by defective hemoglobin synthesis in thalassemia and sideroblastic anemia, leaving these visible blue dots inside the cell.
Our rods are myeloperoxidase, or MPO, cytoplasmic inclusions, pathognomonic for acute myeloid leukemia, AML.
MPO is an enzyme found in the primary granules of myeloid cells. Our rods are abnormal, crystalline aggregates of this MPO. Their presence in the blast cells confirms that the leukemia originates from the myeloid line, often signaling a specific subtype of AML.
Tennis racket-shaped cytoplasmic organelles on EM are Burbeck granules, pointing to Langerhans cell histiocytosis.
Langerhans cells are dendritic cells. In this proliferative disorder, these abnormal cells are distinguished by these unique pentalaminar, rod-like, or racket-shaped inclusions seen only under electron microscopy.
Two critical neuroimaging findings start with epidural hematoma. A large, biconvex, high-density collection on CT suggests rupture of the middle meningeal artery.
This artery sits just under the skull bone. Trauma tears it, resulting in high-pressure arterial bleeding. Because the bleeding occurs above the dura mater, which is tightly bound to the skull, the blood collection cannot cross the cranial sutures. This confinement gives it the characteristic, sharply defined biconvex or lens-shaped appearance.
In contrast, a subdural hematoma is crescent-shaped, caused by bridging veins rupture.
The bridging veins cross the space between the brain surface and the dura. Rapid deceleration or trauma tears these delicate veins. Since the bleeding is venous, it's lower pressure, allowing the blood to spread widely over the surface of the brain, creating the crescent or sickle shape. Unlike the epidural, the subdural collection crosses suture lines.
Let's dedicate time to glomerulonephritis microscopy findings. These are essential for pathology differentiation.
We're looking at where the immune complexes land and how the GBM responds.
A lumpy-bumpy appearance of glomeruli on staining is associated with infection-related GN.
This granular, lumpy-bumpy appearance is due to the deposition of immune complexes, IgG, IgM, and C3, in the subepithelial space, as seen commonly in post-streptococcal GN.
Tram-track appearance of capillary loops.
Membranoproliferative GN. This is the visual consequence of the GBM splitting. Mesangial cells grow into the membrane, attempting repair, creating a characteristic double contour around the capillary loop, giving the appearance of parallel tramlines.
Spike and dome appearance of subepithelial deposits.
Membranous nephropathy. This is an autoimmune response where antibodies deposit on the outer surface of the GBM, those are the domes. The GBM then attempts to grow new material around these deposits, forming little projections or spikes.
And wire loop glomeruli.
The classic finding for severe lupus nephritis. It results from massive subendothelial deposition of immune complexes that cause significant thickening of the capillary walls, making them look stiff and prominent like wire loops.
Finally, we must review key autoantibodies. Anticyclic citrullonated peptide antibodies, anti-CCP, are highly specific for rheumatoid arthritis.
RA is joint inflammation driven by an autoimmune attack. Citrullination is a normal post-translational modification, but in RA, the body generates antibodies against these modified proteins. The high specificity of anti-CCP makes it an invaluable early diagnostic marker.
Anti-dsDNA and anti-Smith are the signatures of SLE.
Anti-dsDNA targets double-stranded DNA and is highly correlated with the activity and severity of the disease, especially kidney involvement. Anti-Smith targets small nuclear ribonuclear proteins and is less sensitive but extremely specific. Both reflect the central role of nuclear debris in driving the systemic inflammation of lupus.
Anti-topoisomerase, or SERO70.
Diffuse scleroderma. Scleroderma is the pathological overproduction of collagen. SERO70 antibodies are associated with the diffuse form of the disease, indicating rapid and extensive fibrosis of the skin and internal organs, making it a critical prognostic marker.
And anti-desmoglein 3-in-1.
Pemphigus vulgaris. Desmogleins are the adhesion molecules that form desmosomes, holding the epidermal keratinocytes together. The antibody attack, a type 2 hypersensitivity, disrupts these connections within the epidermis, leading to the characteristic fragile, easily ruptured blisters of pemphigus vulgaris.
This section turns isolated facts into connected knowledge, showing how one condition leads to another or how genetics dictates susceptibility.
Right. Let's start with mitochondrial inheritance. The rule is that the disease occurs in all offspring of affected females.
This is one of the few patterns that breaks the rules of Mendelian inheritance.
Absolutely. Mitochondria are inherited solely from the ovum, meaning they come exclusively from the mother. The sperm's mitochondria are usually destroyed. Therefore, any mitochondrial DNA disease follows the maternal line. A mother passes it to all her children, but only the daughters can pass it on to the next generation.
HLA-DR3 and DR4 links rheumatoid arthritis, type 1 diabetes, and Addison disease. This genetic signature predisposes to multiple distinct autoimmune pathologies.
HLA molecules are essential for presenting antigens to T cells. Certain HLA alleles, particularly DR3 and DR4, are less effective at screening out self-antigens. DR4 alone, for instance, is highly associated with rheumatoid arthritis.
So it's a systemic predisposition.
Right. The fact that these three distinct autoimmune diseases targeting joints, pancreatic beta cells, and the adrenal cortex share this common genetic background emphasizes that the predisposition to immune misfiring is systemic, even if the target organ is specific.
Let's discuss the common sources of infective endocarditis, differentiating the bacteria by the clinical scenario.
Okay, so if we see S. aureus, we think acute endocarditis, often associated with intravenous drug use, as it's the most common pathogen overall and often affects previously healthy valves. If S. galolyticus, formerly S. bovis, is isolated, that is a red flag.
Immediately work up for colon cancer.
Immediately. G. viridans suggests a dental procedure or oral source, as it is normal oral flora. Finally, S. epidermidis is tied to prosthetic valves because it is skin flora that adheres easily to foreign material and forms a biofilm.
Metastasis patterns. Why do primary tumors consistently metastasize to certain organs?
Metastasis isn't random. It follows the path of blood and lymph drainage, and the tumor cells must find a compatible microenvironment to thrive. Breast cancer often goes to the bone, lung, brain, and liver. Colon cancer drains via the portal system, so the first stop is almost always the liver, followed by the lungs. And prostate cancer has a notable tropism for bone, likely due to factors produced there.
The MN syndromes, multiple endocrine neoplasia, are genetic syndromes leading to hyperplasia or tumors in multiple endocrine glands. MNN1 is the 3Ps.
Pituitary, parathyroid, and pancreatic tumors. MNN1 is caused by a mutation in the MNN1 tumor suppressor gene. The pituitary tumors are often prolactinomas. The pancreatic tumors include gastrinomas, which cause Zollinger-Ellison syndrome, and insulinomas. But the most common manifestation, affecting almost everyone with MNN1, is primary hyperparathyroidism due to parathyroid hyperplasia.
MMN2A and MNN2B are linked by the RET proto-oncogene mutation. Both feature pheochromocytoma and medullary thyroid carcinoma.
The RET gene is a receptor tyrosine kinase. The mutation makes it constitutively active permanently on, promoting unregulated cell growth. MTC is the most critical component because it is aggressive and secretes calcitonin. Pheochromocytoma causes high catecholamine production.
The crucial differentiation. MIN2A adds parathyroid hyperplasia, while MN2B adds mucosal neuromas and a marfanoid habitus.
Right. MNN2A maintains the parathyroid involvement, similar to MN1. MNN2B has distinctive physical findings, ganglion neuromas on the lips and tongue, and a tall, slender, Marfan-like body structure, but notably lacks the hyperparathyroidism.
Let's quickly review Cushing syndrome causes, differentiating between exogenous and endogenous sources.
Cushing syndrome is hypercortisolism. The overwhelming most common cause is therapeutic, exogenous glucocorticoid administration.
So steroid.
Exactly. If the cause is endogenous, we use ACTH levels to differentiate. High ACTH means the signal is coming from outside the adrenals, either from a pituitary adenoma Cushing disease or an ectopic source, like small cell lung cancer. Low ACTH means the adrenal gland itself is autonomous, usually due to a benign adrenal adenoma.
Refractory peptic ulcers are strongly associated with Zollinger-Ellison syndrome, a gastrin-secreting tumor.
A gastrinoma secretes massive unregulated amounts of gastrin. Gastrin powerfully stimulates the parietal cells to produce HCl. This acid hypersecretion overwhelms the stomach and duodenal lining, leading to recurrent or difficult-to-treat ulcers, often found distally in the jejunum. The key diagnostic point is the paradoxical rise in gastrin levels after secretin administration, as secretin normally suppresses gastrin.
We must contrast the two types of esophageal cancer, squamous cell carcinoma versus adenocarcinoma.
SCC is associated with the upper and middle esophagus and is strongly linked to global risk factors like smoking, alcohol, and hot beverage consumption. Adenocarcinoma is associated with the distal esophagus and is the dominant form in the U.S., driven directly by chronic GERD and subsequent Barrett esophagus.
Finally, pancreatic tumors are associated with gallstones, the most common cause of acute pancreatitis, and alcohol, the most common cause of chronic pancreatitis.
This is a high-yield differentiation in gastroenterology. Acute pancreatitis is sudden inflammation, most commonly caused by a gallstone temporarily blocking the pancreatic duct. Chronic pancreatitis is slow, irreversible damage, overwhelmingly caused by chronic alcohol abuse, leading to fibrosis, calcification, and eventual loss of endocrine and exocrine function.
This section takes the physics, statistics, and chemistry of disease and turns it into actionable numbers. Understanding these equations isn't just theory, it explains how we manage and test the diseases we just discussed.
Right, and pharmacokinetics is how the body acts on a drug. The volume of distribution, VD, is key. It's the amount of drug in the body divided by the plasma drug concentration.
Why does VD matter for calculating a loading dose?
VD reflects whether a drug stays primarily in the bloodstream, a low VD, or is widely sequestered in peripheral tissues like fat or muscle, a high VD. The loading dose formula is LD equals CPX VDF. If a drug has a huge VD, meaning it disappears rapidly into the tissues, you must give a significantly larger initial dose to achieve the desired therapeutic concentration in the plasma before the drug can be cleared.
So the loading dose bypasses the slow buildup dictated by the drug's half-life.
Exactly. And half-life itself is calculated using VD and clearance. T-ROS 0.7 by VD/DCL.
Which is a very conceptual anchor.
It is. It shows that clearance and distribution are the sole determinants of how long a drug lasts. If you increase the volume a drug distributes into, the VD, it takes longer to clear it, so a longer half-life. If you increase the efficiency of the liver or kidneys to remove it, the CL, the half-life shortens.
Therapeutic index, TI, is the ratio of TD-ERA, the toxic dose, to ED-ERA, the effective dose.
The IWERO, this is the fundamental measure of safety. A high TI means the dose that cures 50% of people is far below the dose that causes toxicity in 50% of people, like penicillin. A low TI, such as with lithium, means the margin of safety is razor thin, and therapeutic drug monitoring is absolutely required to prevent toxicity.
Moving to biostatistics, we distinguish odds ratio, or R, from relative risk, RR. Both are calculated from 2x2 tables, but their application is determined by study design.
RR is the risk of an outcome in the exposed group compared to the unexposed group. You can only calculate RR in a cohort study because you start with a risk-free population and follow them forward to see who develops the disease. You're measuring incidence.
And ORR compares the odds of exposure among those with the disease versus those without the disease.
You have to use OR in a case control study. Since you start with cases and controls and look retrospectively at their exposure, you can't calculate incidence or actual risk, or provides an estimate of the association. Critically, when the disease is rare, with a prevalence less than 10%, the OR mathematically approximates the RR.
And the number needed to treat, NNT, is defined as 1 divided by the ARR, the absolute risk reduction. Why is NNT considered the most clinically relevant metric?
ARR tells you the mathematical difference in outcomes. NNT transforms that math into direct patient care instructions. If the NNT is 50, it means you have to treat 50 patients with this intervention to prevent one bad outcome. It provides crucial context for resource allocation, cost-benefit analysis, and shared decision-making with the patient. A lower NNT is a more impactful treatment.
Finally, sensitivity and specificity. Sensitivity, the true positive rate, tells you how well a test identifies those with the disease.
And specificity, the true negative rate, tells you how well a test identifies those without the disease.
So what's the clinical takeaway?
A simple way to remember their clinical use. If a test is highly sensitive, a negative result effectively rules out the disease. S-no-UTEAD. You use it for screening. If a test is highly specific, a positive result effectively rules in the disease. SBL. You use it for confirmation. They are inversely related. As one increases, the other usually decreases.
Let's look at flow dynamics, starting with cardiac output. CO, X stroke volume, X heart rate.
This is the fundamental definition of pump function. Stroke volume is the volume per beat. Heart rate is beats per minute. CO is the total volume pumped in 1 minute. Any clinical condition that affects preload, afterload, contractility, or rhythm directly changes CO.
Mean arterial pressure, MAP, is defined as CO times total peripheral resistance, TPR. Why is this formula essential for understanding shock and hypertension?
MAP is the driving pressure that perfuses all our vital organs. This formula shows that pressure is maintained by the balance between the pump, the CO, and the vessel tone, the TPR. In hypertension, either CO is high or TPR is high. In shock, MAP is low because either CO has crashed and the body can't compensate enough with TPR, or because TPR has crashed massively, overwhelming a normal or even high CO.
Now to the kidney. Renal clearance is calculated as UXV.
Clearance is the hypothetical volume of plasma the kidney completely cleanses of a substance per unit time. If we use inulin, a substance that is freely filtered but not reabsorbed or secreted, the clearance calculation gives us the exact glomerular filtration rate, the GFR. Creatinine clearance provides a clinically practical estimate of GFR.
Fractional excretion of sodium, FENA, is a highly complex formula, but conceptually, it tells us if the kidney is working or broken.
FENA is the percentage of filtered sodium that is actually excreted. Think of it as the kidney's inventory sheet for salt conservation. When the body is dehydrated, pre-renal failure, the kidney goes into maximum conservation mode, holding on to all available salt. FeNA will be very low, less than 1%. If the kidney itself is damaged, like an ATN, the tubules cannot reabsorb salt effectively, and the FeNA shoots up to over 2%. It immediately separates a functional problem from a structural problem.
Finally, pulmonary physiology. The alveolar gas equation.
Right, PaO air equals PiO, PeCO 0.8. This equation calculates the expected partial pressure of oxygen in the alveoli. It's essential for calculating the alveolar arterial oxygen gradient, the A gradient. The A gradient measures the efficiency of gas exchange.
So a normal gradient means?
A normal gradient means the problem is simply that the patient isn't breathing enough, hypoventilation. An elevated gradient means there is a genuine problem getting oxygen from the alveoli into the blood. Either a diffusion problem like fibrosis or a shunt VQ mismatch like a pulmonary embolism or pneumonia.
Let's review those high-yield drugs that often get muddled together. Imudrone is a complex antiarrhythmic. While classified as a Class 3 COP channel blocker, it has broad effects.
Imudrone is often called the dirty drug because it hits all 4 von Williams antiarrhythmic classes. While its primary action is potassium channel blockade, prolonging the QT interval, it also blocks sodium channels, beta receptors, and calcium channels. This makes it highly effective for refractory arrhythmias, but its pleiotropic effects contribute to its extensive side effect profile, notably pulmonary fibrosis and thyroid toxicity.
Benzodiazepines, like chlorodiazepoxide, are used for alcohol withdrawal, which relies on their GABAergic mechanism.
GABA is the primary inhibitory neurotransmitter in the brain. Benzodiazepines enhance GABA's effect at the GABA receptor, increasing chloride influx and hyperpolarizing the neuron, calming the brain. Alcohol withdrawal is a state of severe CNS excitation. Long-acting benzodiazepines dampen this overactivity, preventing life-threatening seizures and delirium tremens.
Bupropion is used for both depression and smoking cessation, functioning as a N-dopamine reuptake inhibitor.
This is its unique profile. Most standard antidepressants focus on serotonin. Bupropion increases the effective concentration of norepinephrine and dopamine, improving mood and concentration. The dopamine boost is what makes it uniquely effective for reducing cravings and withdrawal symptoms associated with nicotine dependence.
Contrast mifepristone and misoprostol.
Mifepristone is a progesterone receptor antagonist. By blocking the effect of progesterone, it stops the pregnancy from progressing by destabilizing the uterine lining. Misoprostol is a synthetic prostaglandin EO analog. Prostaglandins cause powerful uterine contractions, ensuring the contents are expelled. They work synergistically.
And the opioid management pair, naloxone and naltrexone. Both are opioid receptor antagonists.
Naloxone is the acute agent. It has a high affinity for the receptor but a short half-life, meaning it quickly displaces the opioid to reverse overdose symptoms. Naltrexone is the chronic management tool. It's an oral, long-acting antagonist used to prevent the euphoria associated with subsequent opioid use. It's also highly effective in reducing the craving for alcohol.
Finally, rifampin, the antitubercular agent. It inhibits DNA-dependent RNA polymerase. The source also notes it increases NH-heros in immunogenic bacteria.
Rifampin physically binds to and blocks the bacterial enzyme that synthesizes RNA, effectively halting all gene expression and replication, a crucial step in treating tuberculosis. The note on NHR is likely a conceptual bridge to its non-absorbable analog, rifamycin, which is used in hepatic encephalopathy not as an antibiotic, but specifically to kill the gut bacteria that produce ammonia, thereby reducing the systemic ammonia load.
We have completed an exhaustive survey of this incredibly dense material, spanning from the single gene mutation in Lesch-Nyhan syndrome causing systemic metabolic failure, through the precision of quantitative physiology like MAP and FENA, and into the complex world of targeted pharmacology.
That's right. We didn't just review facts. We dissected mechanisms. We saw how the location of a protein defect, proximal versus distal tubule, dictates the fate of bicarbonate in the RTAs, and how the mechanism of rupture in an atherosclerotic plaque is the immediate gateway to a life-threatening MI. We connected hundreds of isolated pieces of information into a comprehensive framework of understanding.
You now have a conceptual map of the body's vulnerabilities and defenses. You know why the sweat is salty in CF, why the eye is red in Tay-Sachs, and why a specific HLA marker can predispose you to 3 different autoimmune diseases.
And this leaves us with one final thought to mull over. We extensively detailed diseases caused by single specific genetic instructions gone wrong, like ATP7B failure in Wilson disease or CFTR misfolding. If the ultimate pathology stems from one single line of faulty code, and given the rapidly advancing potential of targeted gene therapies, which aim to correct these precise instructions, what are the ethical and technical challenges of moving the complexity of lifelong management entirely into the single, potentially curative act of genetic correction? The stakes couldn't be higher.